welcome to a lecture entitled COVID-19 and Inflammatory Bowel Disease. This lecture is part of the Pacific Northwest Crohn's and Colitis Foundation chapter patient education event for the fall of 2020. My name is Elisa Boden, and I will be talking to you today about COVID-19 and inflammatory bowel disease. I work at Virginia Mason Medical Center in Seattle in our Inflammatory Bowel Disease Center of Excellence. So the things that I'm going to be touching on today are telling you a little bit about what COVID-19 is. We'll be talking about how it affects IBD patients and their providers. We're going to be talking about how should IBD patients balance the risk of disease control and infection prevention. And then I'll give you some expert recommendations regarding IBD and COVID. And I would just like to remind everybody, and I will be coming back to this later in this discussion, that we're still learning a lot about COVID-19 and there's a lot that we don't know yet. So it's really important that you stay up to date with your doctor's visits. Many doctors are doing telehealth visits for those patients who can't come into the office or have concerns about coming into the office. But please keep in touch with your doctors because they're going to have the most up-to-date information as it comes out on COVID-19 and IBD. So what is a coronavirus? I know everybody's been hearing about this special virus. Coronaviruses are actually a large family of RNA viruses. RNA refers to the type of genetic material that's in the virus. And these coronaviruses cause illness that go anywhere from just the common cold or to cases of severe pneumonia. Many of you may have heard in the news about some diseases that are caused by coronaviruses in the past years. Coronaviruses are the cause of SARS, or the severe acute respiratory syndrome, MERS, Middle Eastern respiratory syndrome outbreaks that have happened across the world, and SARS-CoV, which is the cause of this pandemic that we're having in 2020, is very interesting because it very closely resembles a coronavirus that's found in bats. And we think most likely that this virus jumped species from bats to humans at some point. And it's now the third leading cause of death in the United States. So it's obviously something that is on all of our minds, and we want to know how to protect ourselves best in this environment. Coronavirus enters the body through a specialized receptor called ACE2, and this is found in the lungs, intestines, and tongue. We think the majority of transmission occurs through droplet transmission, and this is transmission where small respiratory droplets that are made through speaking, singing, close contact occur between one or more people. These little droplets that can come when patients cough or when people cough around you, they require close contact with that person, and they don't remain in the air over time. So you actually have to be in close contact with that other person. It's also become a possibility that this virus is transmitted through airborne inhalation of aerosols. And it's not entirely clear how much transmission is occurring through this route. Aerosolization happens when tiny viral particles get into the air and make contacts with things like dust in the air, and they can actually stay in the air for prolonged periods of time, and they can travel long distances. Again, we don't know how much this impacts transmission on a day-to-day basis of COVID, but it probably does play a factor for potential for transmission during procedures from patients to their providers. And so we are taking special precautions, as many of you know who have come in for procedures, to make sure that we are both protecting patients and protecting their providers from inhalation of aerosols. There also may be some transmission that happens from contaminated surfaces. It's not entirely clear, again, how much this contributes to the overall transmission of COVID-19. And additionally, virus has been found in stool. It's interesting to note that that we find it in stool, and some of you may have seen in the news recently, they've been using this to screen dorms at college campuses, actually looking in the waste and seeing if they can find high levels of the virus. It's a very ingenious way, I think, to look for this in larger populations of patients. So we do find virus in the stool. It's found in much less quantities than in the respiratory tract, but there's been no evidence to date that it can be transmitted from the stool to another person if it were inhaled or ingested in some way. So we don't know how much that, we don't think that plays a large role in transmission, but it might be an interesting way to diagnose coronavirus. So just to go back to some definitions, COVID-19 stands for Coronavirus Disease 2019 when it was identified, and this refers to the disease in humans. SARS-CoV-2 is the virus that causes COVID-19. We'll talk a little bit about isolation, and that's when we separate an individual who has known disease from other people so that they don't transmit the disease. And then you probably have heard a lot about quarantine. There's all sorts of quarantine jokes and memes going around. But this is when we're separating, technically when we're separating an exposed individual who does not have the disease to other individuals to prevent spread. We've used it in a broader sense, obviously, in our communities to say that anyone would be separating themselves from others as not to transmit disease if they had it asymptomatically and didn't know. So what are the symptoms of COVID-19? So the majority of patients will experience cough and fever. Patients can have body aches, headaches, shortness of breath, that's what dyspnea stands for, sore throat, and then I've highlighted some things that patients with inflammatory bowel disease also experience and can be a little bit confusing. So patients with COVID-19 can develop diarrhea, nausea and vomiting, and abdominal pain. And again, these are things that sometimes people with inflammatory bowel disease have. So it might be difficult to discern the symptoms of a flare of disease with COVID-19. One of the funny things we also see with COVID-19 is the loss of smell or taste. We call this anosmia. And this is something that's relatively unique, but not entirely unique to this virus. So if you do lose your smell or taste, it is something that would be important to tell your doctor about. And then just to say that only the minority of people with COVID-19 actually have a runny nose, and a runny nose is a very common symptom for other things. So not a common symptom for COVID-19. COVID-19 comes in 3 stages of symptomatic disease, and I'm not going to go into this in a huge amount of detail, but just to say that many patients have either mild symptoms or maybe asymptomatic with infection. The incubation period seems to be somewhere between 4 and 12 days from the time of exposure to when patients might develop symptoms. And then if they do develop symptoms, there is the viral response stage, which is stage 1. That's early in infection, where patients might have mild symptoms like cough, fever, diarrhea, and headache, and some laboratory abnormalities that go along with that. In stage 2, a certain portion of patients develop the pulmonary phase, which is where they get the pneumonia, and that's where they have inflammation in the lungs and actually some fluid in the lungs that can cause shortness of breath and low oxygen saturations. At this point, they may have an abnormal chest X-ray or CT scan and some other laboratory abnormalities. And then stage 3 occurs when there's actually a very exuberant immune response to the virus, and we call this the hyperinflammation phase. And this is where the host body, again, is causing a lot of inflammation to try to get rid of the virus. And this is when patients can get quite sick, where they can have this acute respiratory distress syndrome where their lungs fail and they might need to be put on respiratory support, or they have shock or heart failure. And again, we see lots of laboratory changes that go on during this portion of the disease. Now, there are no approved therapies for the treatment of COVID-19 yet. There are lots of things that are being studied. Some of them are listed here. Certainly convalescent plasma. This is taking the blood plasma from a patient who has recovered from COVID-19 and giving it to someone who's very sick from it. So remdesivir is another one that's being used in clinical trials and in compassionate use. And then there are some other potential therapies that have been discussed, and even things like we might use to treat inflammatory bowel disease are being discussed as potential treatments for COVID-19, like JAK inhibitors or medications that inhibit the inflammatory cytokine IL-6, because IL-6 seems to be an important cytokine, which is a protein that's made by the body during this host inflammatory phase that does damage. So it's interesting that some of the medicines that we use to treat inflammatory bowel disease might also treat the extreme stages of COVID-19. But again, this is all speculation because we have no trials that have looked at these medications in patients with COVID-19. So who gets severe disease in COVID-19? And this is just a pyramid showing that the majority of cases are mild or asymptomatic. Over 80% of people who get COVID-19 have either mild symptoms or no symptoms at all. About 15% of patients get severe disease. That means they may be admitted to the hospital or treated by a doctor. And about 5% of patients get critical life-threatening disease, meaning they're in an intensive care unit or requiring support of their breathing. There are risk factors that have been identified that predispose patients to having more severe disease in the general population. So this is not specific for inflammatory bowel disease. Age is one of the most important risk factors. So there's increased risk of death with older age, particularly age 60 and older. Male gender is slightly associated with increased disease severity. Patients who have cancer, lung disease, who have had an organ transplant. Patients who are obese, excuse me. Patients who have heart disease or heart failure, diabetes, and sickle cell disease are all at increased risk for having severe disease, including death from COVID-19. So I think one question that I've been very interested in, and my patients are very interested in, are whether patients who have inflammatory bowel disease are more at risk to develop COVID-19. And the reason that this might be true is that we know that COVID-19 can potentially enter through the GI tract. So the receptor for COVID-19 virus is in the GI tract. We don't know that it enters that way, but it's one possibility. And it's possible that disruption in the GI barrier could create an entry point for the virus. Patients with inflammatory bowel disease may be chronically ill. So that might reduce the immune system's ability to deal with a virus. Our patients are often on immune suppressing medications. So there's a question of whether those may put patients at risk. And they often have exposure to healthcare facilities. So patients who are coming in frequently for infusions or have to have procedures done or office visits may have increased risk of exposure with those exposures to the healthcare facility. However, preliminary studies, and again, I would caution to say we don't have large numbers of patients, but preliminary studies that have come out of Europe, China, and China have not suggested that COVID cases were enriched for patients with IBD. So we don't see more IBD patients developing COVID than patients in the general population. So for now, we don't think that patients with IBD are more at risk to get the COVID-19 virus. So the next question I wanted to address is whether patients were at IBD at risk for more severe infection if they get it. And to address this, there is a database that's an international consortium has developed to study patients with IBD who have developed coronavirus. It's called the Secure IBD database, and actually there is a website that gives you access to this. If you Google Secure IBD, or I can actually add that on at the end of my presentation, you can actually look in real time what's being submitted to this website database. It's a worldwide web-based voluntary reporting, so physicians are asked to enter any patients who they take care of who have inflammatory bowel disease, who have developed COVID-19. And they recently published an analysis of about 500 patients in the database, but there are now almost 1,000 patients. They looked at factors that were associated with increased risk of hospitalization or death in patients with inflammatory bowel disease. And interestingly, they found, like, just for the general population, that age was a significant factor in disease severity. Having more than 2 serious health problems, like the ones that we discussed on the last slide, were risk factor for serious disease. And interestingly, they also found that the use of steroids and 5-aminosalicylates, so the medicines like mesalamine and sulfasalazine, were also slightly associated with increased risk. There was no increased risk for hospitalization or death when adjusted for age and comorbidities compared to the non-IBD population. So meaning having IBD in and of itself does not put you at increased risk to develop a severe infection with COVID-19. Looking a little bit more closely at the effect of inflammatory bowel disease therapy on the course of COVID-19, they looked to see whether there was increased risk of hospitalization or death in patients who were on certain medications. So when they looked at patients on steroids, there was actually a very significant increased risk of hospitalization or death, 6 times overall the population who was not on these medications. Interestingly, again, with relatively small numbers, the anti-TNF agents, so these are the medications like infliximab Remicade, adalimumab Humira, certolizumab Cimzia, and Simponi golimumab, those medications actually slightly reduce the risk of serious events, hospitalization, or death. And interestingly, there was a just significant, very, very slightly increased risk for patients who were on 5-aminosalicylates and or sulfasalazine. And I want to just mention here, I really think this data needs to be interpreted with caution. First of all, there are relatively low numbers of patients here. And also, patients who were on steroids also probably were on steroids because they were having a flare of their disease. That may have impacted the intensity of this effect for increased risk of hospitalization or death. The other thing is that patients on 5-aminosalicylates and sulfasalazine were more likely to be older. And this was a population we know was at increased risk for having severe COVID-19 infections. So I think there are some what we call confounders. That means that the patients who are on some, particularly for the 5-ASAs and sulfasalazine, the people who were on these medications also may have had other risk factors that made it seem like it was the drug causing the increased risk, but may have been other factors like age and other things that may have caused their increased risk for COVID-19. It's important to note that there were low numbers of patients on ustekinumab or Stelara, but these patients had a very, very low hospitalization rate, so less than 7% compared to 20 or 30% for many of the other drug groups. And ustekinumab does have some properties that reduce IL-6, which is that protein that's created in the host inflammatory response to COVID-19. And there's been some postulation that this drug could have activity against COVID-19. Again, we don't have any data that supports this, but I thought this was an interesting finding. And certainly those patients did not have increased risk of severe COVID-19 when they got infected. The other thing that I would say about this information is that remember that this is a voluntary online reporting system, and that means that the reporting from physicians could be biased in some way, meaning they might be more likely to report patients, for example, on anti-TNF therapy who didn't get sick just to show that it could be safe, rather than patients on mesalamine or sulfasalazine who didn't get sick. So that could explain some of the differences. And again, I think we really need to be cautious in the way that we interpret this. So for the summary that we have on the data so far on COVID and IBD is that there's no evidence for increased susceptibility to infection. There's no evidence for increased risk of complications related to COVID based on IBD itself. The risk of complications in IBD is very, very similar to the general public, which is that it is associated with advanced age and other medical problems, which we call comorbidities. Steroids and 5-aminosalicylates were associated with increased risk for hospitalization and death. But again, this may be related, especially for the 5-ASAs. I want to caution that this may be related to patients who were older and had other medical problems, although the strength of the association with steroids was quite high. And biologics so far do not appear to be associated with poor outcomes in patients with IBD who developed COVID. So what should patients with IBD do with their medications during the pandemic? Should they stop them? And there are a number of experts that have come together. 3 different groups of expert panels have come together to make some recommendations here. And I'm going to review some of those recommendations. So patients who are on immunomodulators, so those are things like methotrexate, 6-MP mercaptopurine, or azathioprine, biologic medications. Again, those are the anti-TNF medications, Entyvio, vedolizumab, or ustekinumab Stelara, or the JAK inhibitors, which is tofacitinib. It is recommended for them to continue. The only time we might think about discontinuing medications is when patients are on combination therapy with azathioprine or 6-MP or methotrexate and another biologic, and their disease is very well controlled. And again, that would be something to discuss with your doctor. Systemic steroids, so that's like prednisone, should be reduced or stopped based on the information that I just shared, that these increase the risk for severe COVID infection. Budesonide, which is the enteric release, this is the formulation that gets released inside the bowels, and most of it does not get absorbed by the entire body. We don't have information on it. It's likely low risk, but again, if it could be discontinued, it would likely be better than being continued. It is recommended that patients keep infusions at an infusion center because it's not clear that a change to home infusions or injection medications reduces risk. Remember, with home infusions, you have a nurse who's traveling from home to home. But it is recommended that you make sure that with your infusion center that there is a screening protocol in place so that staff and patients are wearing masks and personal protective equipment, and that there's adequate distancing. And that obviously, if you are sick in any way, particularly with cough or fever or other symptoms that could be COVID related, that you let your physician know because they might interrupt your dose of medication, and certainly they would want you not to come into the to the infusion center until you were tested. So again, this is taken from some expert recommendations, so about what to do with patients who may be exposed to or infected with COVID-19. It's recommended if you have no symptoms that you try to get off steroids, that you have to talk to your doctor about this, because if you've been on them for a long time, that may involve a taper, a rapid taper, or stopping them. Biologic medications should be delayed until the patient tests negative or does not develop symptoms over 14 days. Thiopurine, methotrexate, and tofacitinib should be held. The 5-ASA medications, it's not entirely clear what to do, but one could consider holding them until the patient is cleared of the virus. And then topical therapy, antibiotics, and dietary therapies can be continued. If patients develop symptoms of COVID-19 after an exposure and a known infection, and their IBD is in remission, again, steroids should be tapered or stopped. Biologics should be delayed until the patient is negative. The immunosuppression should be held. Again, with 5-ASAs, it's not entirely clear what to do, but considered to hold those. And then again, topical therapy, antibiotics, and diet to be continued. If the patient is having symptoms of COVID-19 and an IBD flare, this becomes a very complicated situation because we don't exactly want to stop therapy. And I think this is a time where individualized care is really, really necessary. So the doctor is going to be weighing the risks of the IBD flare and how serious the COVID infection is in the context of what the patient's other medical problems, age, etc. are. So this will be steroids. Again, we want to stop biologics. We will have individualized therapy, and especially it may be reasonable to use those biologics that are hypothesized to potentially have positive effect on the COVID-19 viral response, such as JAK inhibitors, tofacitinib, or Stelara ustekinumab. Again, individualized therapies for immune modulators, 5-ASAs and 5-ASAs, and again, topical therapies, antibiotics, and diet can likely be continued. So what about whether COVID-19 can cause a flare of IBD? And I think we don't know the answer to this. This is something that we'll be very interested to learn about as time goes on. I think the important things to know are that symptoms of COVID-19 can mimic inflammatory bowel disease flare. So we talked about nausea, abdominal pain, diarrhea can occur due to the virus. However, the GI symptoms in COVID-19 generally resolve within a few weeks. We don't know what happens to the disease course, but I think one thing that's important is that if you do have a flare in your symptoms, I'm really testing all of my patients for COVID-19, even if they're not having respiratory symptoms, because there are a fraction of patients that can have only GI symptoms. And I think especially before we start a new therapy for inflammatory bowel disease, it's important to know whether the patient is positive. So how can I reduce my risk? And this is really things that we're telling the general public. So this is stuff that comes from the CDC website where you can go. We are recommending that everybody wash their hands frequently for at least 20 seconds or use hand sanitizer that is at least 60 to 70% alcohol. If you can stay home and work from home safely, please do so. And if you need a note from your doctor, they would be happy to provide that from you. We are requesting that people avoid travel in places that they would be enclosed in a small space or in close proximity to other people. Wear a face mask when you are going to be in contact with other people. Try to stay at least 6 feet apart from other people. Keep surfaces and commonly used spaces clean. Obviously, if you're coughing or sneezing, cover your cough. But really, if you're coughing and sneezing, you should be staying home as not to avoid contact with other people who you might infect. So what else can we do to keep ourselves healthy? So I really, really want to encourage people to stay in touch with their IBD physicians. This is a time where it's easy to say, I will deal with this later, but it's important for your IBD doctor to know what's going on with you and to treat you appropriately, and also to keep you updated on what's new with COVID-19 and IBD. Many of our physicians, I think almost everybody these days, is using telehealth, and it is fairly easy to access, and we can do a lot of our visits through telehealth and just bring people in when they need to come in for procedures or exams. We're using a lot more blood and stool testing, where we used to use endoscopy and colonoscopy. So looking at the C-reactive protein and calprotectin, which is the stool inflammatory marker that can tell us how active your Crohn's or ulcerative colitis is. And we're trying to avoid endoscopy and colonoscopy unless it's likely to change our disease management. We also may be using more imaging where there's a little bit less exposure to other patients and staff. Elective procedures can be delayed in some cases, but these should be discussed with your provider, and it really depends on what your risk is and why we're doing the procedures. You know, again, for colon cancer surveillance in someone who's had multiple precancerous colon polyps, it may be important to keep on schedule, so please talk individually with your doctor. You should avoid hospitalization unless it's necessary, but again, you don't want to stay home if you're really sick. So if you are really sick, please be in contact with your doctor. It is more important than ever to stay updated with your vaccines. Really important for flu, which is out now in most places, and the pneumonia vaccination series. Again, there's going to be overlap between COVID-19 and flu season and bacterial pneumonias, and we want you to be as protected as possible. I also would have a very low threshold to come in for a test for COVID-19 with a flare of symptoms, or if you're changing therapy, to make sure you don't have an infection before you make a change in therapy. And I am starting to consider, if we're starting a new medication, considering injectables as first line if there is a good injectable alternative, just to avoid people having to come in or have home infusions. So I wanted to just share a little bit of data that came out on the implementation of telehealth in this pandemic. So this is an article that was published recently, and it's really just to show for IBD that prior to the pandemic, most visits were being done face to face. That's this green block. During the pandemic, this really expanded to telephone and video, and I think most people are doing video these days. This was an international study, and a lot of this was done in Europe. But look how quickly we were able to expand to providing telehealth to patients. And then this is a question about what people plan to do after the pandemic. And you can see that about half of these telehealth visits converted back into inpatient visits, face-to-face visits. But I think the goal is really to keep the possibility of telehealth open. It is very convenient for patients. And I think for patients with inflammatory bowel disease, especially who are doing well, it's a really good way to check in with your provider without necessarily having to come in for an appointment. And I'm hoping that it makes the distribution of healthcare even easier in the future and more convenient. So the last thing I want to talk about is coping with stress and anxiety. And this has been a big one, I think, for all of us, particularly in the healthcare field, but also, you know, everybody is feeling the strain of this. There are a lot of things you can do. I think limiting exposure to the media is really designed to get your attention, and it does that by scaring you. And there's a lot of media out there, and I encourage people to just really streamline what they're taking in if it's causing a lot of anxiety. Talk to your healthcare team. There are definitely resources out there. If you're really feeling like you need to reach out to a mental health professional, that is so important in these times. One of the things that I talk about with everybody, including my patients, is to plan what you'll do if you become ill. If someone did get exposed to COVID in your family, what would you do? How would you protect other people? How would you protect yourself? And I think having that plan in place gives a lot of security so that you don't have to worry about that piece of it. Begin a stress management practice. So this is super individualized. It can be whatever you want. I love to meditate. That's what I do. But meditation, yoga, exercise, talking to other people, connecting with friends and family, and with the Crohn's and Colitis Foundation. So there are a lot of resources out there. We are all affected by this, and I encourage you all to reach out there for some help. And then I said this in the beginning, but I really want to be cautious. There are a lot of rapidly changing messages. So there was a lot of news media around hydroxychloroquine, that it was going to be great for treating this disease. Then people went back on it and said it's not great. And the bottom line is we really don't have a lot of solid information. So make sure where you're getting your information is from a reputable source. Do not take a medication without talking to your physician about it. Make sure that the news you're getting is real, because really there is very, very little solid data out there yet. As it comes out, we will learn more and more. But it's important to stay updated as well. So again, keep checking in with your doctor just to make sure that you're doing everything right to keep yourself as healthy as possible. And here are some credible sources that you can go to: the Centers for Disease Control, World Health Organization, and also your local health department. And then, of course, visit the Crohn's and Colitis Foundation website. They have updated information. They have a section devoted to coronavirus and what IBD patients should know. It's a great website. I looked to it myself for some information in preparing this talk, and I hope you guys all can visit that. So I'm going to leave you with a little bit of humor, but I am really looking forward to seeing you all on Sunday, February 13th, when I can answer questions about coronavirus and inflammatory bowel disease. And I will be ready and waiting to answer all of your questions. Thank you so much for your attention.